All right. Well, today on the show we have James Crawley with ear, nose, and throat. Been in the game for about 16 years. Is that accurate?
That's correct.
Man, and he's about ready to spread some knowledge on us right now. So we're gonna grill him with a bunch of questions.
Can't wait. Let's get into it. Welcome to the next episode of the Many Minds podcast, where our goal is to encourage collaborative community healthcare using many minds for better outcomes. We want to understand what makes your specialty special and how we can support you to provide better care for your patients. I'm Alex Davis, physician assistant, along with Tyler Murray, nurse practitioner.
General disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. We're just here to learn from each other and have a good time. Been in the game for 16 years, and you are currently at the Orem Revere ENT?
Yeah, so Dr. Robbins' main office is in Provo.
Okay.
So I was with 3 surgeons.
Watch out for our decorations.
We were in Payson and Orem and even Spanish Fork, and then I'd go to Gunnison once a month.
Wow.
But then those 2 of them retired, and then the other one was younger, and I'd worked with him for like 4.5 years, but Ogden Clinic recruited him, and he was from up there, so he went up there.
So they had to turn around.
We closed Payson and Spanish Fork, and so I just kept the Orem one running and joined Dr. Robbins in January of last year.
Is there anything going on at Salem Revere, like ENT-wise?
No. So Dr. Gibb, who I had worked for, had built the building in Payson, so there's no reason to go and pay rent to people.
That makes sense.
They wanted us to move there. It's a nice building, but...
Yeah, you're like, that doesn't make sense.
Are you from this area originally then?
Born and raised in Sandy. We live in American
you're close by.
Yeah.
Then went down to Arizona for school.
Yep.
And then came right back? Or what was the transition after school?
Went to school down there, but I wanted to move back. My wife and I are both from here.
Yeah.
And Phoenix is really hot, if you didn't know that.
I've been there in the summer. It's a little bit warm.
It's hot.
Yeah.
Mucho caliente.
It was like, while we were down there, it didn't drop below 100, even at night, for over 30-something days. And then we come up here, and it's like 90s. I'm like, this is amazing.
Don't tell anybody, but it's perfect here.
Yeah.
We don't need any more people.
So, I was looking for work to come back here, and so I did some rotations here and interviewed and got a job with ENT. And that was I wanted to do ENT, so I did my elective in ENT out at the University of Cincinnati. My brother-in-law's an ENT, and he was out there doing his 5th-year residency, and so they let me go out there. They'd never had a PA or anything.
Oh, cool.
And so I just followed around the residents while I was out there, and it was amazing. And
I think that's a trend as of late, seeing that advanced practitioners taking a step into territories where there isn't really an advanced practitioner role, and I love to see that. That is so unique.
I feel like the profession has been around for a long time, and there's been a lot of recognition for it, but still
these subspecialties.
Yeah, we keep finding, you're not the only one. We keep finding people that are just paving the way of blazing the new trail for opportunity.
So what did that look like when you were out there?
It was awesome. So they had never had a PA, so they just had me follow their 5th-year residents. So I just hung around with my brother-in-law, and he sent me, there's I can't remember, probably 5 or 6 of them.
Yeah.
And so, first day there, the University of Cincinnati is a huge ENT program too, like throughout the country. There was people from Israel, Argentina, students coming to watch surgeries there while I was in. So it was really cool to be there, but it's super intense too. They're calling them to the ER for everything. So the first day I go there was an attempted suicide where the guy had blown his eye out. So I'm seeing that. And then a kid's thrown from a car, teenager or something. Yeah. His head's split open. And they're like, go sew it up. I was like, me? And they're like, yeah.
Guy?
We'll tell you. We'll tell you how to do it. I was like, are you kidding me? Wow. And then getting in there, they're just telling me step by step what to do.
Put you in the front lines.
It was amazing. And then same day, this kid had this huge mass removed from his nose. And so we're going up there, and I'm watching him take 18 feet of gauze out of his nose. Whoa. It was amazing. So needless to say, I worked way more than I ever did there in any other rotations. We would be there at 5:30 in the morning doing rounds, surgery all day, clinic, and then have to round on all those patients at the end. I was like, and they were exhausted. Like, these residents are working, and that's when they had passed a law where they couldn't work more than 80 hours. And if they did, they had to write a paper, so they had to work more and explain why they worked more than 80 hours.
Punishment.
But being there, I was like, you guys need a PA, like, to help you round. You guys need a PA to, like, help you, like, lighten your load. And so, being in Arizona, I know the Mayo Clinic down there had a fellowship, an ENT fellowship for 1 year for new grads. So they train you really well. And I was like, you guys should do a fellowship here. And so one of the docs before I left at the University of Cincinnati, like, was asking me about it, and come to find out they did that. They have a fellowship for PAs there in ENT. And so it's kind of cool to see it. And they're using PAs on their floor now.
Dang, you really are paving the way.
No, it was cool.
That's
and
legit.
Then coming back here, it was kind of cool because my brother-in-law, he's in Colorado as an ENT surgeon, but he was looking to come back to Utah too. So he had a whole list of every ENT in Utah. So he just gave me that, and I just cold called every ENT in Utah and said, do you want a PA? And none of them had them. And I was the first PA in ear, nose, and throat in Utah County. Like, and all of them have them now. But so that was kind of cool.
Trendsetter.
It was just like,
but I imagine though, in that setting though, like, you probably probably was a step back from what you were involved in out of state here, just with the type of patients you were seeing day to day.
Oh yeah. Like at the university setting versus like general practice. Oh, for sure. Yeah. Like, I don't know if I want to be involved in that. It was like so much work. And like those patients, the rotation I was on head and neck cancer. And so like, so much more smoking out there. Like, I swear everyone was born with a cigarette in their mouth. Like, because they would just walk in. We had like, I don't know how many patients that were in there with huge head and neck cancers. Those surgeries are massive. And so they're there for 6 weeks that you're rounding on them. They're like in the hospital. So that's a lot of work. And we don't have that, like, which is nice for a balance.
I'm impressed though that immediately you got right into a specialty and knew that from the get-go. That's right where you wanted to go. And I'm impressed by the dedication to seek out appropriate training and then get right into the spot you wanted to be in.
It worked out.
What's the original motivation though? Why choose that?
My brother-in-law, I think, he's a cool guy, and I was like, hey, it'd be cool to work with him someday. And so you got one elective at the school I went to, and so I was like, I'll see if I can set it up with him, and it worked out great. So I set it up with him, and he's in Colorado. They've tried to offer me to go out there and work with him a couple times, but I like where we live, and he's in a good group. But it would be great. But
okay.
Yeah, that's.
Well, help us understand, I guess, what is the day-to-day in ear, nose, and throat? We were just talking about this a little bit probably before we got going here, but do you subspecialize? Are there folks that within ENT only do hearing, or are there, I guess, other types of subspecialties in there? I guess, tell us a little bit about your day-to-day.
So we're just general ENT, and that's what most ENTs are. But you can there's ENTs that do fellowships in like just ears, so they're otologists. Like at the university settings, there'll be laryngologists that do all the big laryngeal surgeries, and there's some guys here too that do that. But for general, we're just general. So we see the youngest of the young, oldest of the old. So everything from tubes, tonsils to chronic sinusitis to we do a lot of thyroid and parathyroid surgery, and then. So day to day, like I'm just by myself every day. If I need anything, I just call Dr. Robbins. He's in Provo at that office, and he's great. And that's how it's been with the other docs too. I've been by myself for a long time. So usually 9 to 5. We do surgery. I assist Tuesday mornings and Monday mornings. And those are usually thyroids or parathyroids, usually 1 or 2 quick cases, and then go to clinic. So it's a good balance. I like doing both. I like the variety of patients, that it's like young, old, everywhere in between. And it's just the general stuff though. Lots of tubes, tonsils, sinusitis, breathing issues through the nose, chronic ear problems, dizziness. So my first 2 surgeons didn't enjoy dizzy patients. And so you find your niche too. You want to be like a valuable part of the practice. So they sent them all to me. So I got really comfortable with dizzy patients and see a lot.
What would you say your clinical pearls are with the dizziness symptoms, patients coming in? Kind of what things are you screening for? What things are you looking at?
Great question. So it's overwhelming, right? Like, because dizziness it's
all over.
Caused by
so many different things.
I feel like similar to headache. Everybody's had headaches.
Right. And I don't deal with those. We see a lot of that too. But with like dizzy, it was overwhelming at first. And my brother-in-law, who's an ENT, he's like, your job is to figure out if it's ear or not. That's the number one thing. Like, figure out if it's ear or not. If it's not, get them pointed in the right direction. So that's like a good like guidance for me. And then there's main ear vertigo issues that present pretty classically, and so just the key, I feel like, is letting them talk. And the rule is, I always tell them, you can't use the word dizzy and you can't use the word vertigo, but if they can describe, that's the most helpful thing, because those terms are so vague.
They are. Have you seen the ICD code for vertigo? Have you?
Dizziness and giddiness.
That's all I can find. Dizziness and giddiness is how that's described for the ICD code for vertigo.
Funny.
It's always hard to put that one in.
I know. I didn't feel like they were giddy.
But
yeah, exactly. That's funny. No, so I see quite a few dizzy patients, and and if it's not ear, then I'm making them the best guess possible. We refer a lot to cardiology, neurology.
Yeah. When it is ear, what are you seeing mostly? Like, what is going on?
So there's 4 main types of inner ear dizziness, but it's always room spinning. It'll cause violent room spinning. So the most common is BPPV. That's the classic one. They just roll over in bed and the room starts spinning. And you can see it after trauma, but I'd say more often than not, they don't have any history of hitting their head or car accident or something, but it can happen. So that's by far the most common. So I check for that on everybody just with the Dix-Hallpike. And it's that a lot of times, even if they have another type of dizziness, they'll have that too. And so you can actually treat that in the office with an EPWI easily. And that changes their life. Like I had an old lady that had it. She was a little German lady, super sweet. She'd had it for 40 years and nobody had diagnosed her with it. So she couldn't turn right. So she'd turn left to go right. She'd literally do a circle to go right.
Oh my goodness.
No.
And then a couple EPWI maneuvers later and she could turn right.
Oh my goodness.
But oftentimes it'll go away even if you don't treat it after a month or so. Meniere's disease is another one. Mm-hmm. So that presents pretty classically too.
Which is chronic and ongoing and not necessarily, I guess, curable?
No, you can treat it and control it usually. Yeah. Like some not.
Yeah.
But so violent room spinning lasts 4 or 5 hours and their ear plugs up, ringing, and hearing loss in that one ear. And 4 or 5 hours, then they're totally drained, throwing up, they go sleep and they wake up and they feel better. And then it'll come back, like you said, randomly, days, weeks, months later. But that's why it's disconcerting, because you're like, when is this going to hit? It's like so scary. That's like dizziness is the scariest thing for patients. Like they get sweaty. It just sends your body into fight or flight. They're nauseous. They're sweaty. It's awful.
Oh my gosh.
But so we treat them low salt diet and diuretic. Yeah. And they often can keep it away.
Cool.
Just with that, which is huge.
Yeah. What's the weirdest thing you've pulled out of somebody's ear?
Oh, that's a great question. So
you're looking in a lot of ears, I imagine.
Oh yeah. I've only had 5 bugs.
5 live bugs?
Yeah, 2 ticks. That was the ticks were tough to get out. One was the guy thought he had an ear infection. It was a tick eating his eardrum, just going to town.
Oh my gosh.
We look under a microscope to clean the ears and get that stuff out. So ticks,
it's not just the otoscope?
No. Those ticks under a microscope are creepy. and they're big. So yeah, we had an 11-year-old.
You had your ears checked recently?
Yeah.
Makes you wonder. Yeah. Sorry, go ahead.
No, you're good. Like patients that have a bug in their ear, though, like people think they're on drugs or whatever because it's driving them crazy.
Oh, man.
Like, can you imagine something moving in there?
Yeah.
Like it's just
psychosis.
crazy.
Yeah, you're like, oh my gosh, get this thing out of here.
Yeah, but it's hard. So little kids usually is what you're treating, right? They'll put a toy or something in there, right? And so you have to clean that out under a microscope. And this kid's like freaked out and moving.
Sure.
So you got the nurse holding their head there. The mom like strapped them down, holding their arms down. And you're looking under a microscope and their ear is just moving like this under the microscope. So you're just like trying to time it. And just like trying to stay calm. But we had an 11-year-old girl that had a corn kernel in her ear. So I was like, oh, let's just hold still, try and clean it out. But it was like way too painful, right?
Yeah.
She couldn't hold still. She's too big to hold down. So we had to schedule her for surgery, and Dr. Entz went in to remove it, and it was growing into her skin because it's organic, right? And
it was taking root.
Yes.
Oh,
and it was
no.
hard to get out. Like even under surgery with her asleep, like getting it out was not easy, he said.
Oh my goodness.
Gardening in the ear.
Yeah.
Ticks and corn stalks.
Yeah, don't get
not
too
what I
hot.
expected.
That's crazy.
Yeah. So getting some
my
popcorn and she
goodness.
gets a high fever.
Oh, I
fever
feel
cream
for that
popcorn.
patient though. My goodness.
Yeah.
Yeah, so
Yeah, it's probably
type of stuff.
underappreciated. Something so tiny can be so troublesome. I can imagine.
right. Yep.
Moving a little bit away from the ears, so one of the crossovers that we have is some of our patients postoperatively will have difficulties with dysphagia and sometimes dysphonia or vocal cord disturbances, mostly after anterior approaches. Are you involved in any capacity with evaluation of that or treating that?
Yeah, so we see, with our thyroids, similar recurrent laryngeal nerve can be
Yes, that's the
injured.
one.
Yeah. And so it's less than 1% chance with our thyroidectomies, but that's something I talk to patients about, and that's what I'll see the post-ops a lot of the times, and so you pick up on it right away. The weak, breathy voice, the difficulty swallowing, aspirating. So usually, like, we're really careful, obviously, like you guys. We have a nerve monitor going, and so the incidence is low, but if that happens, we usually give it time because usually it's not injured. Sometimes it's just stretched or something. So sometimes it'll recover with time. Sorry, keep hitting that tree.
Bush is going to get you.
Take it out. So if it doesn't recover, though, like what I talk to the patients about, a lot of times the other vocal cord will actually start compensating and coming across the midline, which is nice. But you can inject filler into that one that's paralyzed, that's not moving, and so that gives it enough volume where you get closure. And then,
are you doing that procedure or?
Good question. Usually that's done with the surgeon.
Okay.
Under anesthesia. That's one approach. Just go through the mouth, inject it. Dr. Van Heel, who I worked with, we would do them in the office, and not so much with that, but you can do it for. When patients get older, sometimes their vocal cords will bow and they'll get that weaker voice, and so you can inject it for that reason too, and it gives it more volume, their voice gets stronger. So he would do that through the skin. So I would scope him with a flexible scope through the nose, so we're watching it on the screen, and then he's going through the skin in the office, and I'm watching the needle, and I'm telling you're a little high, you're a little low.
Wow.
And patients did well with it, but it was pretty fun. Yeah, that was like different.
That was just the surgeon's preference of how to approach that.
Yeah, saved them money, not having to go to the OR.
It's a cool
The
tag team
patients
approach.
Yeah, it was fun to be a part of it, and so we did several of those, and the patients did.
And they're like light sedation or kind of what?
They're totally awake. He just numbs them up like on the skin, and so when we're done, we're like testing the voice, like making them talk and see if it's improved, and it was really cool.
That's crazy.
Yeah, I did several of those. So yes, we are involved with that, and then we'll usually get speech pathology involved for swallowing evaluation, help them with swallowing.
When you say give us some time, what would your time frame look like, with a potential recurrent laryngeal nerve injury? How long?
So a few months.
Really?
Usually, yeah.
I wondered that because,
doing.
Sometimes we get antsy when the patient comes in 1 month post-op and we see that their voice is hoarse or they're having some issues. I'm like, how soon do we send them to ENT? And what would your response be?
No, that's a good question. So I'll usually see them after our surgery a couple weeks after, and so if it's present and they're having a hard time swallowing, I'll do the referral right then for speech pathology to get helping on the swallowing so they're not aspirating or they feel more confident with that. But as far as like doing the injection, I usually would say let's follow up in another month, and I'll usually have the doc see them too, and
just measuring the severity of symptoms
and see if it's improving at all. If it's not improving at all, maybe if we see some movement, then maybe we wait still before we do anything. So it's patient by patient, but it's probably about that time frame. The nerves, like you guys, take longer than anything to heal if there's any injury.
Makes sense.
But
How's your balance been with working and getting some time away, clinic versus OR? How do you feel like you've been able to balance that out?
It's been good. That's what I love about this specialty in my job. I think one ENT said, it's like referred to as like early out in tennis specialty, like everyone. So anytime I need time off, it's been easy to get time off, and so it's been awesome just being involved with my kids' lives and help coach and stuff. It's been awesome.
But you're 5 days a week?
I am, yeah.
5 days a week.
So we used to, with the other surgeons I was with, they hated everyone like referring patients to them at the end of the day on Friday. So he's like, we just got to leave before them. So we started leaving at 3:30 and then 3, and then it went to 1. And now I'm done at 3:30 on Fridays.
And what's your clinic load like?
Like patient-wise?
Yeah, on a regular clinic day.
Yeah, anywhere from like 18 to 25, 26 is a busy day. And some days are slower, but usually it's been pretty busy.
And then any kind of call responsibilities, and it sounds like weekends and rounding and that kind of thing as well?
Yeah, so that's been really nice too. So we don't have any patients that like stay overnight at hospitals.
Nice.
We don't even go to hospitals anymore. We just do outpatient surgery. And so I used to early on, I would have to go around on patients or discharge them basically. Like our thyroids would stay overnight. That was probably basically it. And they were usually doing great, and we just send them home. They all go home now, and so I don't remember the last time I had to round on a patient at the hospital.
That's awesome.
And then call has been super easy. Like the other surgeons I was with, I would choose the days I wanted, 10 days a month usually. And I was usually first call, one of them was second call, and most of the stuff is like I don't have to go in. It's just like refilling their pain meds for a post-op patient or answering questions from a post-op patient. Nosebleeds, I had to go in a handful of times in 16 years. And then the real significant bleeds are like tonsillectomy, post-op bleeds, and so the surgeon has to go in for that because they're going to have to go to the OR and stop it. Yeah.
You guys are a service, though, that's consulted either through the ER or on the floor of the hospital from time to time.
Yeah. We used to be on call at Utah Valley, and we don't do surgery anymore there, so we're never on call there. Really. Not on call we used to be on call at like Mountain View ER, but we're not down there anymore. And so... And then Temp, we used to be on call there. We're not on call there anymore.
So here's the question, going back to nosebleeds. Is Coke still used to treat nosebleeds? Does the hospital have a supply?
No, they used to, like when I first started, like they'd use it in ENT surgery. Like when I was at the University of Cincinnati, they used some. But so we use just, no, I don't think so. They just use tetracaine and epinephrine.
They've gone away from the Coke.
Yeah, for nosebleeds, I'll numb up the nose with afrin and lidocaine. And just soak it and put it in the nose. But the funny thing is, like, I put that in a patient's nose once, and he's like, "Oh, this feels like cocaine." I was like, you do cocaine.
You're like, "Oh, great, thanks for sharing. Let's put that in his history."
I had another patient before I looked in his nose. He's like, "It's going to be crazy. I just want you to know I dealt a lot of cocaine. I did a lot of cocaine." I was like,
and was there?
Yeah, the septum was a huge hole in it. Yeah, I'll tell you a story at the end.
Okay.
We're opening doors. Here we go.
Can't wait for that.
It's a vasoconstrictor and numbs it up.
It made sense for a lot of years, I'm sure.
Until they don't want to have it on hand.
Yeah. That's not in the medication cart.
It's not the cartel. Got it.
Exactly. Maybe that was a cash pay. I don't know.
Yeah.
Now kind of spilling over into compensation.
That's a natural transition.
Cartel compensation. In the ENT world, though, how do you feel across the board with advanced practitioners? You're compensated.
No, that's a good question. So, listening to your podcast, I'm like, whoa, they make a lot more than me.
It's been eye-opening, actually. It's been interesting to hear people's experience.
They make that much. So looking across the board, like across the country, it's a range from like, I think the average is like 110 to like 145, depending on where you're at. And Utah's usually lower. So here, I think I looked and it was like 110. And so, I'm above that. I'm more to the higher end than that. So, because I've been here a long time, but I don't know how much the new grads are getting. Because I started out, like, I don't know if you guys, but like back in the day, I think that average was in Utah was 70. You'd start out at 70,000.
Oh boy,
that was the hardest thing, because working as a bedside nurse and then going to the family nurse practitioner, I was like, I think I'm making more money working the floor than I would.
Because you could add more hours.
Exactly. I had a lot more control. That was a hard pill to swallow. But you kind of invest your time and energy into something that will pay dividends in the long term. And I think that's the hope. With your organization, do you feel like there's going to be a ceiling, like you're going to reach this plateau and not be able to progress beyond that? Or
I wondered, but it's funny. So my last meeting with them at my year mark or whatever, they were talking about going to more just paid by what you're doing and seeing if you could make RVUs type of payment and see.
Do you think that would be beneficial for you in that?
I don't know. It's interesting because there's takeaways. So if you take time off,
then you don't get you don't get bonused.
So if there was a combo of the two, I think it would be better, right? If you have a base salary and then if you're performing well and overdoing that,
quarterly bonus or something like that.
That incentivizes everybody.
Because I think that's the challenge with kind of our role, is this idea that if you kind of plateau us, I mean, performance-wise, there's always vulnerability for people to just kind of go through the motions rather than trying to get better, more efficient, and trying to, do what's best for the company as a whole. So I think it is a good mindset for everyone to be in, and how you compensate individuals.
And even from the employer side, that the advanced practitioner has the laterality to jump around as well.
Right.
So if you feel like you've plateaued or you're getting stagnant or you're not challenged or there's not kind of a carrot out in front, then somebody might be also just looking to make moves around, because you can do that fairly easily in our profession.
Right.
Which kind of stemmed this whole idea of the podcast as well, because it's interesting to know what else is happening out there, because theoretically I could jump over and come join you and that wouldn't be too big of a transition. I'm sure it would be, obviously, but theoretically that's there, so it's nice to understand what these situations are.
Oh, totally. Yeah. No, it's been eye-opening. I'm glad you guys are doing this. It's fun.
It's super fun.
I didn't even know about it.
It's super fun.
Good to hear what people are doing.
Yeah. What about another topic I like to ask people is just new and innovative trends in the world of ENT.
Oh, God.
What are some of the cool things that maybe not everybody knows about, or what's coming down the pipeline?
Sheesh, that's a good question. New, and so there's nothing like crazy that we're doing that's way different, right? Scope people, those have been around forever. Like our surgeries obviously are getting like parathyroids, that has changed dramatically since I've been doing them. So they could take forever, right? Because it can be really hard to find those, and you're searching. So we work really closely with the endocrinologist, Dr. Nizam, and he's phenomenal, like identifying them before we even go in. He biopsies them, so he knows. So it's gone from, like, we're done with those in like 45 minutes, and 30 minutes of that is waiting for labs. And so it's, that kind of stuff is cool, just working with them. But like and you probably see more of the real innovative stuff at the universities and stuff, where they're trying stuff out. So one cool story, though, I went to an ENT PA conference down at the Mayo Clinic, and it was a lecture on laryngeal tumors. So usually they're just on one vocal cord, usually from smoking, drinking and stuff. And that's where they used to remove the whole larynx and just pull everything together, give them a trach, and you see those ads where they're talking. So this guy was lecturing, and he's like, they're usually just one-sided. So what we've done is we've gotten a 3D printed CT scan or whatever, and then we 3D printed their larynx, and then we took their stem cells and regrew their tissue over this larynx. And then we just removed the one side and reimplanted this one side, and they're able to talk and everything.
Oh my goodness.
I'm listening to this, I'm like, what in the world? I've never heard of this. So I go up after the lecture, I'm like, who is doing this surgery in the world? Who's doing this? And he's like, me. He was the only one. And he's like, here, check this out. And he's like, this is a patient I just did 3 weeks ago. This is her reading a script. And so he's like, I shouldn't show you this because it's not published yet, but check this out.
That's
and you could understand everything she was saying. I was like, and just like the combination of like technology and medicine, I was like, that is really cool. But we're not doing anything crazy like that.
Sure.
Right.
But that's out there. That's kind of a cool idea. That's kind of the new trend, maybe, is regenerative, restorative things. And
the cochlear implants are getting more and more common and done more for the patients with severe hearing loss.
Yes.
And we don't do those. That's the otologist that will do that. That's the ENT that specializes just in ears.
Yeah.
So
that's amazing.
But there's a lot of stuff. It's come along.
Yeah. I distinctly remember those commercials.
Oh my god!
This little jingle that they had, and he's holding his voice box up. You don't always die from tobacco, and they're saying it could be worse.
Yeah.
Right.
Oh yeah.
It causes all sorts of problems.
Yeah.
Between that and squeezing out the white stuff in their organs. Have you seen that where they're like squeezing it and showing what's
like
inside?
their arteries or something?
Yes.
Oh, okay.
I kind of remember that.
Yes. And I was like, that I'm never going to smoke. Yeah. Pretty sure I'm not going to do that.
How about this is your brain on drugs? You remember that?
Yeah.
The egg in the frying pan?
Yes.
I learned it by watching you, all right?
Right.
I love
Parents
that.
who do drugs have kids who do drugs.
Yes, right. Some good marketing. We've talked about this before in other shows. The marketing people,
It's so true.
more talented than you might think. They'll catch you.
Yeah.
That's awesome. Well, I'm excited to hear the rest of this teaser for the story.
Oh, yeah. So don't do
Let's-
drugs. That's the
Yeah.
message of
Yeah.
the story. So I was in Payson, and the family practice was right behind us. And it was like the end of the day, and the doc called and was like, hey, I want to send this patient to you. It looks like this patient has a hole in the roof of their mouth, from their mouth up into their nose. I was like, okay. Like, I was thinking probably just like some discoloration or something. It's going to create an illusion that there's a hole. So they come over right then. I look up in their mouth, and there's a hole like going up into the nose. I'm like, that is crazy. So I look in the nose, and I don't know if you've ever looked in the nose when there's no anatomy. It's like crazy. So everything was gone. There was no septum, no turbinates. It's just this open cavity.
Wide open.
So when you have no anatomy, it's really like disconnected. Like, wait a minute. Okay, what am I looking? Oh my gosh, there's nothing in here. And I was like, so have you done any drugs? And she's like, admitted to snorting Percocet. And that was, so it's just like super interesting. Like, a lot of these drugs are vasoconstrictors, and the blood supply is sacrificed, and then they're not getting nutrients, and the tissue just dies, and it's just gone. And so she did have a hole from her mouth up into her nose, and the interesting thing was that her biggest complaint was it had distorted her voice so much that on telephone calls people couldn't understand her because it was reverberating up in her nose. So people couldn't hear what she was saying. It was super interesting. Like, that was her biggest complaint with it. And so her daughter would have to like help out with phone calls and stuff.
Sure.
So we went, and what they were going to try and do was rotate the skin of the nose over that hole, or the roof of the mouth over that hole. It's one and the same, right? But they went to do that, and it just disintegrated. The tissue was so...
It wasn't viable.
Yeah, and so she ended up having to just go and get some plates put in and reconstruction and stuff. But so don't do drugs.
Don't do drugs. Take home message of the day.
Yeah.
Dare.
Yeah.
Yes. It's still true today.
Yes.
I've signed my form.
There it is. There you go. Yeah. So, that's what we learned about ear, nose, and throat. Don't do
that
drugs.
sums it up. I think that
Don't
sums
smoke. Don't do drugs.
Yeah, there you go.
Easy enough.
If I could have said anything.
That was it.
James, that's fascinating. I'm actually intrigued by your world. I think what you got going on there is unique, and although you're kind of taking a step back, more of the general stuff, but even within that, it sounds like there's some cool things happening, and even just your knowledge of what's going on in your space. So, man, thanks for coming on the show today.
Thanks for having me.
For
It's been a ton of fun. I always am interested now because I keep getting surprised at all the specialties. I think I've said it before, is when I get into starting these conversations or we're thinking about who's going to come on the show, my first thought is just the generics that you learn in school of tubes and babies and hearing loss in the elderly and things like that. But then we learn there's just a huge depth and breadth to these specialties. You guys are doing great things, and I think a great resource for the community. Anything else you learned?
No, I've been just blown away. I love it. Yeah, thanks for coming on the show
Thanks
today.
for having us. Or
Yeah.
Me.
Thanks for having us. Well, you're representing the ENT
Yes.
space
Yes,
right now, so we're going with
Yes.
it. Yep.
Doing it all. If someone wanted to follow up with you, James, how would they reach out to you?
Good question. So
You're all
so
over
we have an
social
off-
media, right?
Yeah, exactly. No, I'm not. For ENT
You and
stuff.
everyone else. What are we doing? We
I don't
gotta
know.
get out there more.
Yeah, it's true. It's true.
Yeah, I'm not at all on the social media stuff. So just our office, like we can help you out with any general ENT stuff. So Dr. Robbins is in Provo. He's down in like the Cotton Tree Square area.
And this is with Revere.
Revere
Yep.
Health ENT, and then I'm in Orem at the Timpanogos Hospital. It's the same number, 801-375-3175, and that can get you a hold of us and help you out with any ENT problems, or if you're
Love
dizzy.
that.
If you're dizzy, but don't say vertigo.
Yeah, exactly.
That's right. With our office is on social media. Tyler not so much. Me, not so much. But connect with our office. We love to interact with people that way. On Instagram, it's Summit Brain, Spine, and Orthopedics. On YouTube, the Summit Medical Institute. And then we always love seeing people in person. We do a multidisciplinary case rounds discussion every Tuesday morning, 7 a.m. at the Mountain Point Hospital in Lehi, Utah. We appreciate our production team as always. Dallin and Amelia holding down the fort for us.
My guy.
Shout out to anybody that's listening. Please give us a review, feedback, subscribe. Let us know.
Come on the show.
Come on the show with us. Let us know what specialty you want to hear from, or if you yourself want to come chat with us. We'd love to have you. And I'm looking forward to what's coming up in the future. Stay tuned. We got a couple of great ones. We'll finish out what will be season 1 with a couple great episodes.
Some bangers. Come on.
Yeah, we do. Yeah. So we appreciate everybody listening to this episode of the Many Minds podcast, where we are encouraging collaborative community healthcare using many minds for better outcomes. I'm Alex Davis.
I'm Tyler Murray.
We'll see you guys next time.